Good afternoon, everybody. Happy New Year to everyone. This is the second lecture in Sonobuzz. I'm extremely privileged to share my views on genetic counseling. Let us go straight to the topic. Any woman who is pregnant is at risk of having a fetus with aneuploidy. And this risk is called as a background risk or a priori risk. And according to the age, we have tables which tell at a particular age what is the risk for a woman to have a child with a fetus affected with trisomy 21. Now, the question is, can we detect and diagnose genetic abnormalities most of the times? The answer would be yes, but with a combination of multiple parameters, especially three methods for detecting aneuploidy. One is by the use of serum biochemistry, other by use of sonography, and the third by use of DNA testing. When we talk about serum biochemistry, we have the double marker test in the first trimester, triple, quadruple, and penta screening in the second trimester. So in the first trimester, sonography plays an important role in giving us certain clues telling that this fetus could be at risk for aneuploidy or other genetic abnormalities. We will quickly go through the markers of the first trimester aneuploidy. This is normal nuchal translucency, and this is increased nuchal translucency. This is normal nasal bone demonstration, and this is unossified nasal bone in the first trimester and in the second trimester. This is a normal tricuspid waveform with E and A waves without regurgitation, and this is a large pansystolic waveform from a tricuspid valve with regurgitation. This is a normal ductus venosus waveform with a forward flow during the atrial contraction. That is, the A wave is always forward. And this is an abnormal ductus venosus showing a reversed A wave or an A wave reversal, which is a marker for aneuploidy. So these are the common 4 aneuploidy markers, which give us an indication that this fetus could be at a higher risk for aneuploidy. So a combination of the maternal age and any one of these markers or multiple markers, along with the maternal serum, beta HCG and PAPA, will give us a risk for aneuploidy. In the first trimester, we have to use certain softwares for arriving at the risk, and these softwares will ask you for the patient details, the maternal age, maternal weight, maternal height, background conditions of the mother, like diabetes, SLE, lupus, etc. Also details about previous gestations, and the input page for the present details would have the CRL, the details about the nuchal translucency, the thickness, the nasal bone presence or absence, the tricuspid valve regurgitation, ductus venosus regurgitation, the uterine Dopplers and their PIs. And using a combination of the maternal age, maternal race, maternal weight, height, the CRL, the nuchal translucency, and also if we have the blood sample of the patient, by a combination of beta HCG, PAPA, MOMS, we can arrive at a risk in the end of the first trimester. So at the end of the first trimester, the maternal a priori risk is converted into a combination of ultrasound findings and the maternal serum markers, which is called as the combined risk or the first trimester risk. So at the end of the first trimester, we will have to assign a risk for the mother. So when the risk for the fetus comes as less than 1 in 1,000, we call it as low risk and no more testing is required. We can proceed to an 18-week STIFA scan. When the risk comes as a high risk, which is more than 1 in 250, then we need to counsel for a chorion-villus sampling, or we need to ask for a 16 weeks anomaly scan for TIFA scan followed by an amniocentesis. When the patient has a risk between 1 in 250 to 1 in 1,000, then this is called as intermediate risk. In cases of intermediate risk, we have to advise for a 16-week genetic sonogram or an NIPT, and then take a call at the 17th week whether to go for an invasive testing or not. So this is how a risk is assigned at the end of first trimester. So the maternal age-related risk is converted to a first trimester risk at the end of first trimester. We move on to the second trimester, where we have the chance to do a triple marker test. or a quadruple marker test. And then we have the ultrasound, which can be called as a genetic sonogram or a TIFA scan. So when we do our TIFA scan or genetic sonogram, we have certain findings which are called as soft markers of fetal aneuploidy. Okay. So these are usually seen between the 18 and 22 weeks. These are not abnormalities, but indicate an underlying aneuploidy or a non-chromosomal abnormality. So we will quickly look at the second trimester aneuploidy markers. The first marker is the nasal bone, which can be absent and which will be called as an unossified nasal bone. The second would be an enlargement of the cerebral-lateral ventricle, which would be called as ventriculomegaly when it exceeds 10 millimeters in the axial plane in an anterior-posterior in a mediolateral direction. Third is a thickened nuchal fold, which is a measurement of the nuchal fold thickness in the axial plane. Fourth is an aberrant right subclavian artery, which arises as a last branch from the aorta and moves towards the right shoulder, close to the spine in the posterior mediastinum. Then we have the echogenic bowel, which is an increased echogenicity of the bowel, which is equal to or more than the bone. And then we have pelvic ectasia, which is an increase in the anterior-posterior dimension of the renal pelvis, measuring more than 4 millimeters. Then we have echogenic intracardiac foci, which are echogenic nodular structures on the papillary muscles of either or one cardiac ventricle. Then we have single umbilical artery, which shows a two-vessel cord, and we have choroid plexuses, which are cystic structures in the choroid plexus, and we have enlarged cisterna magna, where it measures more than 10 millimeters. A lot of analysis has been done on these second trimester markers, and one of the best compilation of all these analysis is by Agatha Cleos, which is an article which says meta-analysis of second trimester markers. So this second trimester markers from almost 15 to 20 studies of these markers have been collated, and then the findings for the increased findings for echogenic focus, ventriculomegaly, increased nuchal fold, etc. All the markers have been collated, and they have arrived at detection rates, false positive rate, likelihood ratio, positive likelihood ratio, negative likelihood ratio, and likelihood ratio when there is an isolated marker. I would spend a minute more here for us to understand what this means. In the second trimester, the aneuploidy markers are unossified nasal bone, aberrant right subclavian artery, ventriculomegaly, increased nuchal fold, echogenic bowel, pelvic ectasia, echogenic intracardiac focus, short humerus, short femur. Now, each of these markers indicate the presence of aneuploidy by themselves or by combination. And each of these markers, according to their strengths of identifying aneuploidy, have a positive likelihood ratio and a negative likelihood ratio. And when these markers are isolated, then we have a single likelihood ratio. Now, likelihood ratios talks about the strengths of these markers and their ability to identify aneuploidy. And if you see that the likelihood ratios are arranged in their descending order, with the nasal bone having 6.5 as the highest, URSA, ventriculomegaly, and increased nuchal fold having approximately 3.8, echogenic bowel having 1.6, and pelvic ectasia, echogenic focus, short humerus, short femur having 1. So these are arranged in their descending order, and you can see we can group them into 4 groups. The first group is unossified nasal bone with 6.5 as a likelihood ratio. The second group, which has URSA, ventriculomegaly, and increased NF, all of them in the upper part of the body, having likelihood ratio of half of 6.5 approximately, which is 3.8. The third group is echogenic bowel, which has a likelihood ratio of half of it, 1.6. And the last group with all the four markers with a likelihood ratio of 1. So the numbers to be remembered are 6.5, 3.8, 1.6, 1.0, approximately half of each. So this is how we need to group these likelihood ratios into 4 groups, and remember the numbers. Now let us see how we can do risk assessment so that we can do genetic counseling. When the patient comes, she comes with an age risk. Then we convert the age risk using a first trimester scan and give a scan risk. Then we send them for a double marker test and combine the first trimester scan report and arrive at a first trimester risk. At the end of first trimester risk, we have a first trimester risk. Then if we do a triple marker or quadruple marker and a TIFA scan or genetic sonogram in the second trimester, we can arrive at a sequential risk. So using these results, we can come to a final risk after our genetic sonogram at the 18th week. Now, according to how people use these variables, names of the risk assessment programs are derived. So you can see that the variables are AFP, HCG, estriol, inhibin, PAPA, NT. And if the first trimester scan and double marker is used, it's called combined test. If only triple marker test is used, it's called triple test. If only quadruple marker used, it's called quadruple test. If the first trimester scan, PAPA, and the second trimester serum markers are used, it's called integrated test. If only the first trimester serum and second trimester serum test is used, it's called serum integrated test. If you use a first trimester scan, first trimester double marker, second trimester quadruple marker, it's called a sequential test. So you can see that the performance increases as we add on the test, and by using a sequential scan, we can detect 95% of aneuploidies. So if you use only NT, you can detect 64% of aneuploidy. If you use NT and double marker, you can detect 82% of aneuploidies. If you use a triple marker alone, you can detect 69% of aneuploidies. A quadruple can detect 81% of aneuploidies. An integrated scan can detect 94% of aneuploidies, and serum integrated 85%. So if you see here, it is the integrated scan which uses first trimester NT, PAPA, quadruple screen, which gives 94 to 96% detection rate. So the more parameters we use, the more detection rate and less false positive rate. Coming to twins, if we have a dichorionic diamniotic twins, then we can measure the NTs separately, we can look at the NB separately, and then we can arrive at a fetus specific risk. But when we have monochorionic twins, triplets, or vanishing twin, then we can only arrive at a pregnancy specific risk. It is not possible to get a fetus specific risk. So at the end of second trimester, either by using a first trimester risk and a second trimester scan, or by various methods, we arrive at a second trimester risk. Again here, if the risk is less than 1 in 1,000, no need to do any further testing. If the risk is more than 1 in 250, then we proceed with an invasive testing, which is usually an amniocentesis. If the risk is between 1 in 250 to 1 in 1,000, then we quickly proceed for an invasive testing. Some people choose to do non-invasive prenatal diagnosis. Now let us see certain examples which quickly will make us understand how to calculate the risk. So here we have a 30-year-old mother who walks in with a risk of 1 in 900, which is intermediate. After the NT scan, her risk falls to 1 in 5,600. Then we send her for double marker test, which is normal, so her risk falls to 1 in 3,000. And her anomaly scan is normal, so her new risk is 1 in 6,000. So this is the scenario when all the parameters we have used is normal. Now let us see what happens if the FTS is abnormal. So she comes in with a risk of 1 in 900. She has a scan risk of 1 in 5,600, but her PAPA is low. So what happens? The risk becomes high. The 1 in 5,600 becomes 1 in 200 because these serum markers are abnormal, and she qualifies for a CVS. Now let us see another scenario where the anomaly scan is abnormal. So she comes with 1 in 900. She has an NT scan risk of 1 in 5,600. She has an FTS risk of 1 in 3,000. But then you find that the anomaly scan shows an absent nasal bone. So what happens? We use the likelihood ratio of 6.5. We divide the 3000 by 6.5, and her new risk is 1 in 460, which is an intermediate risk, qualifying her for an amniocentesis. Now we have a scenario where the triple marker test is abnormal. Now she comes in with 1 in 900 based on age. Her NT risk is 1 in 5600, and she does not do a double marker test, but she goes for a triple marker test, which is abnormal, and the risk becomes 1 in 550. But then you proceed with the genetic sonogram, and if it is normal, her risk becomes 1 in 1100, and it's a double of 550, and the new risk is low, and then we counsel them not to do anything. So in this situation, even though the triple marker risk has come abnormal, there is a first trimester risk which is very efficient, which is low risk, and there is this sonogram which does not show aneuploidy. So the new risk 1 in 1100 does not require an invasive testing. Look at this slide carefully. If a TIFA scan is done, which includes all the aneuploidy markers, including URSA and humerus, then the negative likelihood ratio is 0.13. That means the pre-test risk gets reduced by a factor of 7.7. But if you're able to do only a routine anomaly scan, then the pre-test risk gets reduced by a factor of 1.9 or 2. So remember these two numbers, 7.7 and 2.0. So if you do a genetic sonogram, you can reduce the risk by a factor of 7.7. If you do a routine anomaly scan, you can reduce the risk by a factor of 2.0. So that is the way in which you can alter the risk after your genetic sonogram. There are a lot of examples which I have put up, which can make us understand how to calculate risk. When we have a single sonographic marker of fetal aneuploidy in the second trimester, then it is easy to calculate the risk. So let us say the patient comes with a first trimester risk of 1 in 3002, and we find an unossified nasal bone. Since the likelihood ratio of unossified nasal bone is 6.5, you divide 3002 by 6.5, you arrive at 1 in 461, which makes it a high risk, and the counseling for amniocentesis should be done. Now, in case we have thickened nuchal fold or ventriculomegaly or URSA, not in combination, any one of this, then the likelihood ratio we apply is 3.7. So the first trimester risk of 3002 is divided by 3.7, and we get 1 in 811, which is an intermediate risk. So we can actually counsel them for an amniocentesis or an NIPT and proceed. Now, suppose we have echogenic focus or pelvic ectasia or a single short bone, then the likelihood ratios of these are 1. Hence, the first trimester risk of 3002 divided by 1 remains 3002. So when we have these markers, the risk does not alter, and we have the same risk. So it is easy when there is a single second trimester marker, because all you have to do is just take the likelihood ratio from the table, divide the first trimester risk by the likelihood ratio, and get a new risk. Now let us see if there are two markers. So listen a little carefully. When you have two markers, you cannot just divide them by the two markers. So here we have the first trimester risk of 1 in 3002, and let us assume that in the second trimester, the patient had absent nasal bone and echogenic bowel. Now what we do, we go back to the table and we use the positive likelihood ratio of nasal bone, which is 23. We use the positive likelihood ratio of echogenic bowel, which is 11. Then we take the negative likelihood ratios of all the other 6 markers. So among the 8 markers, 2 are present in the fetus. So we multiply the positive likelihood ratios of these 2 markers. Then the other 6 markers which are absent, we take the negative likelihood ratios and multiply all of them. Then we multiply these 2 numbers and we get a single number, which is 73.3. This is divided by the first trimester risk to arrive at a new risk. So because of the 2 markers, you can see that a risk of 3002 has become a risk in 1 in 41, which is high, and the factor we have used is 73. So if you have a combination of absent nasal bone and echogenic bowel, the factor will be 73. Likewise, I have calculated the factors for various combinations. So if we have a patient with echogenic focus and pelvic ectasia, the factor to be used is 5.6. If you have unossified nasal bone and echogenic bowel, the factor to be used is 73. If you have thickened nuchal fold and ventriculomegaly, the factor is 90. If you have unossified nasal bone and URSA, the factor is 180. Now look at this. You have three markers: unossified nasal bone, thickened nuchal fold, ventriculomegaly. The factor is 5170. As the number of markers increase and as the markers with higher likelihood ratio combination increases, the factors themselves increase, and then the new risk becomes very high. So by using these factors, the the first trimester risk is altered into new risks, and we get a second trimester risk. So in the second trimester risk, we have to manually calculate the risks by using the table which I showed, which will have the positive likelihood ratios, negative likelihood ratios, and we can use these in arriving at a new risk. Finally, the same method after arriving at the second trimester risk by using a single number when it's an isolated finding, or by using a combination of numbers, we can arrive at a new risk. And according to the risk, we stratify the patient to low risk, intermediate risk, and high risk, and then proceed with counseling. Now we will quickly look at genetic counseling. Genetic counseling can be offered for various indications: advanced paternal and maternal age, previous child or family history of congenital anomaly, dysmorphism, intellectual disability, developmental delay, isolated birth defect, metabolic disorder, chromosomal abnormality, myopathy, ambiguous genitalia, adult onset disorders, consanguineous marriages, teratogen exposure, repeated pregnancy loss, abnormal pregnancy screening test, which is what we just dealt with, heterozygote screening based on ethnic risk for diseases like sickle cell anemia, Tay-Sachs, Canavans, Gaucher's, thalassemia. So when we consider key considerations for genetic testing are congenital anomalies, previous histories, physical abnormalities, and ultrasound abnormalities. Genetic counseling can be prospective or retrospective. So prospective allows for true prevention of a disease, and it requires heterozygote detection for any defect. So we need to identify and make the couple aware that there is risk of transmission by marrying another heterozygote for the same gene. Retrospective counseling is when there is a pre-existing disease like mental retardation, psychiatric illness, etc., and there is nothing much which can be done here. Chromosomal analysis can be done from amniotic fluid in the antenatal period. FISH or fluorescence in situ hybridization can be done by using specific DNA probes to look at specific chromosomes. Karyotyping can be done to look at the entire 23 pairs of chromosomes and their variations. Chromosomal microarray can be used for looking at microdeletions, duplications, specific breakpoints, etc. And whole exome sequencing can look at protein coding regions, and whole genome sequencing can be used to look at protein coding and regulatory regions. So to put everything together, in the first trimester, we can use sonography and serum biochemistry, and we can use CVS to look for chromosomal abnormalities and gene disorders. Second trimester, we can use sonography and markers and amniocentesis to look for FISH abnormalities, karyotype abnormalities, chromosomal microarrays, and single gene disorders. NIPT can be used anywhere from 10 weeks to 40 weeks to get an assessment of specific chromosomes and specific disorders. When you do genetic counseling, we need to take history of the patient, past history, family history, obstetric history. Carefully do physical examination of the couple or of the affected individuals. We need to construct a pedigree chart with at least 3 generations with sex, age, and state of health. Risk assessment is very important, and when we have to do risk assessment for disorders, we need to understand the mode of inheritance. Diagnosis becomes the crucial step in genetic counseling. Communication needs ample time for discussions. Management options, including medical termination of pregnancies, can be discussed, and we have to connect them to support groups. So when we do genetic counseling for chromosomal abnormalities may be straightforward using the risk assessment which we discussed, but counseling for genetic disorders, we need to understand the pattern of the inheritance of the disease, whether it is autosomal dominant, autosomal recessive, X-linked recessive, dominant, or Y-linked. So we need to understand whether we are dealing with autosomal diseases or when they are autosomal diseases, whether we are dealing with a dominant type of inheritance, a recessive type of inheritance, and then we need to counsel. Pedigree evaluation makes us understand whether the pattern of inheritance is dominant or recessive or otherwise. So we need to understand a lot of terminology which has to be used in these genetic counseling. We need to understand a lot of signages which are used in drawing these pedigree charts. And once we do all this, we can start genetic counseling. Here I give you a template of genetic counseling. Genetic counseling can be done by fetal medicine specialist, radiologist, obstetrician, geneticist. Better it is a combined event. So the template which one can use in the hospital or in your clinic and can go like this. It needs to have patient ID, date, counselor's name and his qualification, patient's name, age, blood group, spouse name, age, blood group, RH incompatibility, married life in years, gravida, para, abortion, life history, family history of mental retardation, physical deformities, mother's history of diabetes, hypertension, epilepsy, thyroid, SLE, APLA, bleeding gums history, drug history, LMP or corrected EDD, type of conception, IVF, IUI, ET details, donor egg or donor sperm, ages, single or multiple gestation, dating scan, reliable or unreliable, NT scan, reliable or unreliable, age risk, NT risk, NT and NB risk, first trimester risk by using beta HCG and PAPA-MOM, triple test if available, quadruple test if available, anomaly scan, what are the findings, final sequential risk, stratification of the risk into low, intermediate and high, need for karyotype, whether non-invasive or invasive, if it's invasive, CVS, amnio or chordosynthesis. Procedure details like technique, OPD or IP, pain, tissue which is obtained, tests which are going to be done on the tissue, like fish, karyotype, PCR, etc. The cost of the test, the advantage of doing the test, risks have to be explained, especially bleeding, water leakage, miscarriage, infection, rate of miscarriage has to be clearly explained. Culture failure and non-availability of karyotype report have to be pre-informed to the patient. Form D by PCP and DT has to be filled. Contact number of the counselor to be given. Appointment for the procedure, insurance detail, blood sugar plus or minus optional. No need to stop ecosprin or heparin. Post-procedure report. Form F to be filled, Form G to be filled, Form D to be filled. Antibiotics like Sporidex optional. Anti-D to be given if there is RH incompatibility. After the invasive procedure, check scan in 3 days where we look for FHR, Liker, cervix. Once the fish report comes in 3 days, there can be recounseling. Once the karyotype report or chromosomal microarray report or the exome report comes, then recounseling can be done in 2 weeks. So that's about first trimester markers, second trimester markers, serum biochemistry, arrival of a risk at first trimester, arrival of a risk at second trimester, usage of software in first trimester, manual calculation in second trimester, risk stratification, and understanding genetic disorders and genetic counseling. Those who are interested can look at my refer series, which is Radiology Education for Enhancement of Radiologists. You can log into drpradeepsrinivasan.medinet.org for courses on fetal genetics and fetal aneuploidy and fetal echo. Thank you very much.
Thank you, sir, very much for that really informative lecture. We have a couple of questions right now. One is Sujit, who asks, what software are you using for checking the risk?
See, in the first trimester, we have both paid and unpaid softwares. I would recommend all of you to take the Fetal Medicine Foundation course, where you have a first trimester short courses on NT, NB, DV, TB, uterine artery Doppler. If you do these 5 courses and upload the images which they ask, then you get a software free of cost from FMF, which you can use for 1 year. At the end of 1 year, you do these short courses again and then upload images. Once you have this software, you can just keep it on your PC in the clinic or in your hospital. Use the software, enter the details, arrive at a risk, and put the risk in your report and quote from where you have put the risk. In the second trimester, however, as I told, you need to have the Agatha Clio's meta-analysis charts. Use the charts, look at whether you have a single marker or look at you have a combination of markers, learn to multiply and divide and arrive at the new risks.
Okay, thank you, sir. Bhumika is asking, is tricuspid regurgitation only a risk marker in the first trimester scan and not in the anomaly scan? If yes, then why?
Okay. As far as tricuspid regurgitation is concerned, in the first trimester, we can look at detecting whether it's there or not. It is a marker both for aneuploidy and for cardiac anomalies. So we do not really jump and do anything when there is an isolated tricuspid regurgitation in the first trimester. We note that there is a tricuspid regurgitation, which could be a marker for aneuploidy or for cardiac disease. And we ask for a double marker test or a quadruple marker test. We reassign the risk using these serum markers, and we do a early anomaly scan or early TIFA scan at 16 weeks and see for persistence of this or disappearance of that. Many times by the second trimester, tricuspid regurgitation, which is an evolving condition, may disappear, and the need for any other test does not exist.
Okay, sir. Geeta Shah is asking, if a dual marker test is done in the first trimester, do you still need a triple, quadruple, or an integrated test?
Yeah. If you see one of the slide which I put, a sequential scan is one where we have a combination of NT scan, dual marker test, and a quadruple marker test. So the detection rate when we use ultrasound at first and second trimester, and when we use serum biochemistry in both the first and second trimester, has a 95% detection rate. Whereas if you use first trimester, second trimester ultrasound and a dual marker without a quadruple or triple marker, the detection rate is about 85%. If you want the 10% increased detection rate, which is called as a sequential screening test, then you can use it. But if you are happy with an 85 to 90% detection rate, you can stop at double marker test.
Okay, sir. There's one more question coming. This is asked by Baldev. I think you've already answered where to get the risk assessment software done. And what is the management for isolated DV reversal in first trimester? How do you approach it?
First of all, whenever we have these markers, we need to see whether the markers are true positive or false positive. We have a lot of instances where the IVC A wave normal reversal can overlap the ductus venosus waveform and look like a abnormal A wave reversal. Because the ductus venosus and IVC are too close, if the sample box is a little wider, then we get an overlapping waveform of both these. This I've actually described as a bright peak sign. So the normal ductus venosus waveform is gray and the IVC waveform is whitish. So if you have a bright A wave reversal and a darker ductus venosus on the other side, then it's a false positive. Now let us assume that you have a true positive ductus venosus reversal, and there again ductus venosus reversal indicates aneuploidy or cardiac anomaly, and it is a pretty strong marker. So what we actually advise is, once we have a ductus venosus reversal isolated, then we immediately do a double marker test. Look at the combination of our NT risk using ductus reversal and the PAPA and beta HCG, and what is the risk at the end of first trimester. Based on this risk, we go for a CVS if it is high. Don't do anything if it is low. Once it's intermediate, then we quickly do a 16-week anomaly scan, reassess the ductus venosus, by which time it could have disappeared, or by which time we could detect probably other cardiac anomalies which has probably given rise to the ductus venous reversal. So we need to take a guarded step whenever we have isolated markers like this with normal serum biochemistry. If the ductus venous reversal has been associated with a lower PAPA or higher beta HCG, and if our first trimester risk is a little higher, then we can put 1 plus 2 together and ask for a CVS, or wait for an early anomaly scan at 16th week, get an additional quadruple marker test or an NIPT, and then reassign the risk and do an amniocentesis at the 17th week if required.
Okay, sir. And if you could just show your slide again, sir, of your refer series. Some people have asked.
Yeah. Okay. Refer series was started 3 years ago by me, where I have courses on fetal echo, fetal aneuploidy, and anal sonography. It is done with the help of an IT company in Bangalore called the Medinit. So the spelling is MEDIKNIT. So you can log into www.medinit.org and look at the courses. These courses are extensively designed. Each course to create has taken me about a year or so. There is extensive discussion on theory. I've used a lot of line diagrams, props whenever possible. Counseling has been done real time with 2 models who are working for the TV industry. About 45 to 1 hour of counseling shooting has been done. And a lot of real time examples are there. A lot of pictures, autopsies, chromosomal examples, reports are available.
Okay, sir. Thank you so much. Thank you for being with us at Sonobuzz. And we hope to see you in person for our next conference, sir. Thank you very much.
Thank you. Thank you very much.
You can just enable the screen share.
Yes.
And we now have Dr. Chander Lulla. He is a master sonologist. What can I say? He is also runs the ultrasound division at Jaslok Hospital, Elizabeth Hospital, and he has his very famous RIA clinic in Mumbai since many, many years. He's been president of IFUMB as well, and I think his name is chalked down every time anyone has a fetal course or a fetal conference. His name comes up first. So Chander, thank you very much for being with us. And if you could just enable your slide share, please.
Thank you, Sanjeev, and the team of Sonobuzz. Can you hear me?
Yes, loud and clear.
Okay, so thank you once again. There was a good prelude by Dr. Pradeep, and these are some of my gurus in fetal medicine, and for all of us, of course, it's Kypros Nicolaitis. And this is one statement that has always been helping me to do fetal medicine, is that fetal treatment was born from clinical frustration, and we used to always have these fetuses at the Vadia Hospital, which nobody wanted anybody to do, and we started doing fetal medicine with these fetuses. So I suggest if you're training, you must join a teaching hospital and sharpen your skills with these unwanted pregnancies. And of course, do no harm is a very important message. Now, there's this often asked question, is this in this era of rapid advancing molecular diagnosis with exome sequences, and as you just heard, NIPT, will it make prenatal imaging and diagnosis interventions a dying art? And I hope to persuade you otherwise. It's very, very, very important that you have expert sonography and imaging and be well versed with all the technological advances in molecular diagnosis and invasive therapies, as we are going to be asked to do more of these technologies, because even genetics is expanding at a very rapid pace, and we have new and new tests which are only amenable to interventive diagnosis. Now, I won't go through all this. Pradeep has already spoken to you about the various genetic abnormalities, which are abnormalities of numbers. So you have aneuploidies, you have tetraploidies, triploidies, uniploidies. You can have mosaicism, where there is a mixed cell line. And then you can have structural abnormalities in the form of small losses and gains. And then uniparental inheritance of abnormalities like Prader-Willi and Angelman, and mutation in de novo. But this slide is really important, is that if you see the year 2011 to 13 has been a landmark year for genetic and prenatal diagnosis. Before this, prenatal diagnosis essentially involved around the trisomies. So trisomy 21 was our focus, and if you see all the prenatal diagnosis, 64% of the results were trisomies. After 2013, the results showed that most of the diagnosis, 50% it dropped to, was aneuploidies, and all other abnormalities started increasing in appearance when we started doing prenatal diagnosis. Not that aneuploidies decreased, but we started picking up other abnormalities. So with this background, I must tell you that fetal interventions has not gone down, although there has been a reduction in unwanted, non-indicated amniocentesis and CVS, which relied only probably on high maternal age or something like that. That has gone down, but we have more and more new tests available, more and more diagnosis possible. So the procedures that we do in form of diagnosis are CVS, that is the chorionic villus sampling, the amniocentesis, fetal blood sampling, and of course some of these are used for therapeutic interventions like amnioinfusion, therapeutic amniocentesis for various conditions. So some of the indications Pradeep has very well highlighted. Of course, in this current era, we consider every woman is at risk, and it's not alone the high maternal age, but these are some of the indications where genetic anomalies can be on a higher side. So you've just seen that high maternal age above 35, high paternal age above 50. If the parents are carriers of chromosomal rearrangements, either balanced or unbalanced or any other such rearrangement, or they're carriers of autosomal dominant or autosomal recessive disorders, they can transmit these to their pregnancies. And then if the parents themselves have an aneuploidy or a mosaic aneuploidy, many mosaic Turners are otherwise normal. If they have a previous pregnancy with a structural defect, so the recurrence rate is about 2 to 3%. Previous aneuploidy recurrence rate is about 1.6 to 8%. But most importantly, today we do prenatal diagnosis for what we call structural anomalies, or on ultrasound, or if the combined screening is positive, that is, you have a nuchal edema or a biochemistry that is possible, and of course, prior to various fetal therapeutic procedures. So what are the indications? We do cytogenetic analysis for all the chromosomal abnormalities I just talked about. So we do short-term culture, long-term culture. We do rapid aneuploidy tests in the form of FISH and QFPCR and microarray. Then there are certain single gene defects like thalassemia, Duchenne's, hemophilia, cystic fibrosis, etc., where we do DNA analysis. And then there are some inherited metabolic disorders, enzyme disorders like mucopolysaccharidosis and others, congenital adrenal hyperplasia, where we also need to do these interventive procedures. So screening approach, you have just seen first trimester, second trimester, and of course anomalies. And by far the biggest boost to prenatal diagnosis has been this one image of nuchal edema, which highlights us to the fact that there is something wrong with the pregnancy. And then we go by Kipros's two-stage screening program, wherein which if your risk is high, more than 1:100, then we offer an invasive diagnosis in the form of CVS. And if its risk is less than 1:100, we order other tests like NIPT or ultrasound in the second trimester. Now here you can see that from the 1960s, we have been doing prenatal diagnosis. It depended heavily on high maternal age, then alpha-fetoprotein, triple screen, quadruple screen, all about 70 to 80% accurate. And then first trimester screening was about 90 to 95% accurate. And here we are on the horizon of near 100% accuracy by NIPT, which is now threateningly being done even at 10 weeks. And you can see in this one paper where they did NIPT without doing an ultrasound, subsequent scans showed various abnormalities in the form of Potter's, hydrocephalus, Epstein's, and that we all know. So this is very important that we should counsel the parents not to do an NIPT before you do an ultrasound. Also, there were two gynecologists who tricked the NIPT laboratories, and they sent samples from non-pregnant women for NIPT, and two of them reported insufficient fetal DNA, whereas 3 laboratories reported a female fetus. So you can see the extent of commerce involved in NIPT, and it's very important, therefore, that we use the unified approach to risk assessment, especially in the era of NIPT. We must offer a combined screen as a first line of investigation. And if the risk is high, move to an invasive test. If the risk is intermediate, then only we should offer a cell-free DNA. And here again, if the risk is high, we again move to an invasive diagnosis. And here also, I must highlight to you that cell-free DNA and combined screening is essentially focused towards aneuploidy. When a woman comes to a genetic clinic or any of us, she doesn't know much about Down syndrome. She just wants to know that her baby is all right. And we therefore have to counsel her about everything is normal in the pregnancy. Now, Down syndrome is like this small mosquito here, whereas you have multiple abnormalities that can be existing if we don't look for them in this scenario. So if you see this chart of maternal age, as you progress beyond 30, your incidence in red of aneuploidy increases. Whereas even at a younger age, your incidence of multiple abnormalities is constant, and this is constantly increasing. So it doesn't matter whether you are below or 30 or above 30. 1% of all babies today can have a neurological handicap from various syndromes, almost 100 genetic syndromes, and microarray can find 40% of them. Microarray can also find about 20% of autism. So it's very important that we keep pace with all the interventive and genetic tests. Now you can see here, this is a fetus with nuchal edema and a little bit of hydrops and short limbs. There is also a cardiac abnormality and some echogenic focus here in the heart. And we did a CVS here. No point in giving this fetus an NIPT. So the moment you have a structural defect like this, this does not only increase the risk for aneuploidy, but there could be multiple other abnormalities. So we did a CVS, and lo and behold, the diagnosis was a glucose phosphatase isomerase deficiency. It is a third most common hemolytic anemia, which I had never heard of. And then we checked the parents, and both the parents were carrier for this gene, which is on the chromosome 19. The point to make here is that when we have a structural abnormality on ultrasound, we no longer rely on dual marker and the NIPT. That's very, very important. For example, again, just to show you another case, this is a case with nuchal edema, which is persistent from the first and second trimester. We did a multiplicity of tests. The FISH, the microarray, the torch, everything was normal. And finally, we did a test for the Noonan syndrome, and the fetus was Noonan's positive. So the PTPN11 gene was positive, and then we found that both the parents are carriers for this gene. So it's very important that ultrasound guides a genetic invasive diagnosis to the parents. So parents need proper counseling. Now, historically, the first test that has been done in genetics is, of course, an amniocentesis from the year 1960 for doing the Liley's curve. They would estimate bilirubin. And if you see CVS, it started in the year 1970 by Chinese observers who wanted to do sex detection. And it was essentially transcervically. This was in the pre-ultrasound era. So they would do a blind cannulation and suck out the villi. And thankfully, of course, this procedure has been given up. In the year 1980s, when we got ultrasound, we started doing ultrasound-guided procedures. So before we move on to any interventive procedure, you, of course, need a PCP-NDT approval, and you need to fill out the relevant forms. You then have proper sterilization maneuvers. These are OPD procedures. You can give a mild sedation to an anxious patient if she so desires, but at most times, just communication is enough. We then prepare the patient with proper sterility. And these are some of the equipments that we use. We use a suction cannula, a condom to cover the probe, or you could use a glove or a probe cover, and a simple spinal needle. You use a sturdy drape. We do cover with antibiotics. It could be Sporidex or Augmentin. And we do use tocolytics in the form of Duadilan 40 milligrams twice for the next 5 days for whatever it's worth, although it's so controversial. And if the mother's blood group is Rh negative, we do give her anti-D. And we also advise the patient to be fasting for at least 2 hours before the procedure. And this is the procedure. We use local anesthesia when we are doing a chorionic villus sampling, although not exactly necessary. You can, if you're very quick, you can do it without local. What's important is that you have ultrasound guidance. And this is the basic important principle of the procedure. This is the important procedure. The needle should be at a 45 degrees to the vertical, and the probe should be at a 45 degrees to the vertical. So both should be at 90 degrees to each other. And then you watch the movement of the needle as you go through into the fetal abdomen. And again, this principle is very, very important. I apologize for the poor quality of the image, but that's the only image I've ever found. The probe has to be perpendicular to the patient, and the patient is in long axis. You can do either in short axis or long axis, but what's most important is the probe should be perpendicular and your needle should be at 45 degrees to the horizontal. And then you measure the distance where the target is. So if your villus is at 3 centimeters deep, then you should be 3 centimeters away from the probe. So you must respect these principles. And then you pass in the needle, which is usually a simple spinal needle. You visualize you have a very good assistant who can connect the connecting cannula for amniocentesis and chorionic villus sampling. And then depending on whether you're doing an amniocentesis, you withdraw about 20 cc's fluid, or if you're doing a CVS, you do the suction technique and you move your finger up and down, and that will allow you to get the sample, which is essentially about 20 grams. So now this is the procedure as we would see it on ultrasound. That's the chorionic plate here, the chorionic frondosome. That's the needle going in. You do about 4 or 5 passes back and forth, create a suction, and the villus tissue will come in automatically into your syringe. So we do the procedure CVS between 10 and 14 weeks. We use a simple spinal needle and we aspirate about 20 grams. And amniocentesis is done between 15 and 20 weeks. And again, we use a thinner needle at times, 22 number, and we aspirate about 22 cc's, 20 cc's. We usually use a single needle technique, but some observers have used a coaxial technique. I don't think it's really necessary. If you're not confident about your technique, then you may need a coaxial. Otherwise, a single needle puncture is good enough. In the coaxial technique, you'll have an outer cannula and an inner needle which goes in, and the cannula remains in place. So you need about 5 or 6 back to forth movements with the vacuum applied. And then, as I said, the post procedure, we give antibiotics, tocolytics, and rest for at least 2 days, and no exercise for 1 week. And very important that you give anti-D if the mother is Rh negative. Now, this is a recently done procedure. Patient had a Fallot's at the first trimester, and you can see that's the anterior placenta. Now, there's this often concern that if your placenta is accessible, you can do a CVS. But what if it's a posterior placenta? And therefore, the transcervical route was better for posterior placentas. And I hope to show you that we can do all placentas transabdominally. As you see here, you go through the skin, subcutaneous tissue, the muscle layer. That's where you may need to talk to the patient, because there's a little bit of pain that the patient gets here when you access the serosa. And once you're in the chorionic villus tissue, then the patient is quite comfortable. So vocal anesthesia is also very, very important. Now, this was the fetus with multiple cysts or a hydropic degeneration of the placenta. And you can see that when you do an amniocentesis, it has to be a very rapid puncture at the anterior side here, free of placenta. It should be at an oblique angle of about 45 degrees, and the procedure should be over in about 20 to 30 seconds. So it should be very rapid. At other times, if you jerk at this side, you may take the amniotic membrane along with you, and you may cause an amniotic separation, and the patient may have a leak. But if it's a very rapid puncture, then this is less likely to happen. Now, these are some different sites. So that's a posterior placenta. You can see fundal posterior. You can either access here, you can either access. I prefer the most vertical part of the placenta, and that's easier to access and you get a good sample, good thickness of placental tissue here. Now, this is another one which is slightly more difficult. It's a thin placenta, not as good as this one, and you can see the needle going in. This is a low-lying posterior placenta here, as you can see here, and you pass the needle from front and you access whatever site is accessible is the best place to get some tissue. Now, if you have a frank posterior placenta, then with the transducer, we push the uterus up, and I'll show you a way to do that. If that's a posterior placenta, you push the uterus in front, and you make the placenta almost anterior and accessible to you. So you can push it as much as you like, and you can see that then you are able to convert this to an accessible placenta, and you can do a chorionic villus sampling in that fashion. Now, you can use color Doppler to identify vessels and then use a plane where there is no vessels, but really speaking, we don't need to do this at most times. Now, very important that you examine the sample once you've done a CVS, and as you can see here, that the chorionic tissue represents the chorionic frondosome. It is a fetal component that you're using, and it can express cytogenic and molecular and biochemical properties of the fetus, and we usually expect to get about 20 grams in those 4 or 5 passes. And you put them on a Petri dish, and you can see the branching pattern of the villus, and then you know that you have done a good job. And it's not, sometimes very erroneously, you could be doing a myometrial sampling. But once you know you're in the placenta, you will get a good sample. Now, as far as the amniotic fluid is concerned, it's usually pale straw-colored, but if the mother's had a bleed or infection, then you can have a very dark brown chocolate or green color amniotic fluid. And these essentially represents exfoliated fetal cells from which the fibroblasts are cultured. Now, why do I prefer CVS? It is an early diagnosis. It's an early procedure. An early diagnosis, there's less fetal bonding at an early stage because there are no movements perceptible, and there's less public knowledge about the pregnancy. So it's very important that if you've got a negative diagnosis, then the risk of first trimester MTP is also lower. So these are the advantages of CVS. And more importantly, there has been this phobia that CVS is more complicated as compared to an amniocentesis. And that was because essentially amnio is a very easy procedure to do compared to a CVS, but the complication rate is essentially similar. In fact, I personally feel it is a safer procedure because there is less risk of chorionic and amniotic membrane rupture as compared to an amniocentesis. And of course, first trimester screening has been a boost for getting the patient early to do a CVS. There can be some disadvantages in the form of confined placental mosaicism and maternal cell contamination, which we will talk about. So amniocentesis is essentially done after 15 weeks. As I told you earlier, we need a firm entry to prevent tenting of the amniotic membrane and try to avoid the placenta and the cord insertion site. And very important that you don't make the patient sleep for a long time before you do the procedures, as the fetal cells will settle and you will not get a representative sample. So it's good to make the patient walk just prior to the procedure. You then discard the first 2-3 mLs and change your syringe of aspiration to avoid maternal cell contamination. Now, there's this controversy of whether to use a 20G needle or a 22G needle for amniocentesis. There have been no reports which suggest that a larger needle can increase the bleeding rate. In fact, the bleeding rates can be similar. The larger caliber needle, in fact, is better because it will allow you to aspirate faster and shorten the procedure time and therefore reduce the complication rate. The fetal Ross rates are all similar, and this has been studied with various needle sizes. Now, what are the tests then? Once you've done a procedure, you have a multitude of tests to deal with, and I think Pradeep just spoke about all this, so I'm just going to briefly run through this. The karyotyping was, of course, our gold standard. As we know now, it's not the gold standard. There are various other tests that are available, but in relevant situations, of course, karyotyping is important, especially when you're suspecting the 5 major aneuploidies. The problem is it's a culture. Sometimes culture can fail, it can get infected, and of course, it takes a longer time for results. we always use a rapid aneuploidy test. Today, we prefer a QF-PCR, but otherwise, we used to use the FISH. And these, again, focus on the 5 major aneuploidies, and you get results in about 24 hours. Now, microarray has provided at least 5 to 10% extra information over and above these tests, and you get results in about 7 days. And you can see deletions and duplications or gains and losses, which were not seen with amniocentesis to the degree of as small as 50 to 200 kb genetic loss. And the results can be obtained in about less than 8 to 10 days. And of course, if you have a family history of an abnormality like Duchenne's, hemophilia, thalassemia, then you can do a Sanger sequencing and of that particular gene mutation. It's a targeted test depending on the family disorder, and you can get results in 3 to 4 days. Or if there is no index case of an abnormality and you have a structural abnormality on ultrasound, then today we go for next generation sequencing in the form of a clinical exome or even sometimes a whole exome. So this is generally the genetic algorithm. When you have a suspected abnormality with a family history or consanguinity, we do serial ultrasound, genetic counseling, and then we do a rapid test, follow it up with either, if the rapid test is positive for aneuploidy, we go straight for karyotyping to know whether this is a balanced translocation, or we go for a microarray. If the FISH is normal, we would go for a microarray, and then if that is normal, we would then save the DNA and go for targeted whole genome sequencing. Now, what if there are multiple pregnancies? So, of course, if it's a monochorionic pregnancy, you need to take a single sample at most times, unless, of course, if there is discrepancy of the phenotype in both the fetuses, you take a single sample. But in a dichorionic pregnancy, if you have a fused placenta, this is what I generally do. I take one sample closer to this edge of this fetus, advance the needle, and go to the other edge. If there are 2 separate placenta, of course, there is no problem. You will take 2 samples in a CVS. If you have doing an amniocentesis, you can take 2 separate samples. Or what I prefer is that you take a sample from this sac and puncture the membrane and take a sample from the second sac. It's good to do that. It's faster. There are times where you have more than twins, you have triplets, because now with infertility treatment, and this was one case, and many of them are carriers of some disease. And before you do a reduction, they need to know whether all the fetuses are involved or not. So this was a triplet. The mother was a hemophilic carrier. So we had to do a CVS of all the 3. And one of the fetuses tested hemophilic positive. And then we would do a reduction at a particular fetus. So this can be a trying task. But what's important is that you map the pregnancy properly. You draw diagrams, because once the results come back, you need to know which fetus is affected, and then you offer an embryo reduction accordingly. So that's very important that you map the pregnancies. Now, the other situation is if you've got one fetus which is abnormal and one fetus which is normal on a dichorionic twin pregnancy, the often asked question is, should we sample both? Yes, you should sample both the pregnancies, because as you see here, that even if you have a dichorionic pregnancy, 6 of 7 are dizygotic, and one of these dichorionic 7 pregnancies can be monozygotic, and you don't know which one is that. So that means that one monozygotic pregnancy could be having a genetic involvement in both the fetuses. So it's a good idea to sample both the fetuses. Now, when we look at the safety and efficacy, the accuracy of all these tests is very high, almost 99.4%. What are the factors that can compromise efficacy, especially if you look at CVS? You can have maternal cell contamination, because ultimately you have a fetal and a maternal component of the placenta. You can have confined placental mosaicism, because the placenta itself can have a mixed cell line, as you know, and this may not be completely representative of the fetus. Fetus may be normal, and yet the placenta may have some mosaic error. And then, of course, laboratory errors, which are fortunately becoming less because everything is getting mechanized. And then in the past, we used to have failure of culture, especially when you're doing karyotyping. And this was essentially if you had very less sample, which was less than 5 milligrams. Now, let's look at some of... Yeah. Hello.
Please go on, Chander. It's
Yeah.
fine.
So maternal cell contamination is common if you look at CVS, and sometimes in amniocentesis, especially if you're doing less than a desired number of procedures, then you can have a bad sample. So it's very important that you do a regular number of procedures, and then the maternal cell contamination will be less. Now, you see, in amniocentesis, the maternal cell contamination is less because sometimes you're culturing the amniocentesis, and here the maternal erythrocytes do not get cultured. So they do not grow along with the fetal cells. Whereas in a CVS sample, it's very difficult to separate the decidua from the fetal villi, and therefore both of them grow, and the chances of MCC are higher. And therefore, we always do a maternal cell contamination test. The laboratory always does this before they give us the results for most procedures nowadays. So you have a test for that. So maternal cells can be detected in amniotic fluid, especially if you are doing a transplacental puncture, or if you're doing more than one puncture, if you've got poor operator experience. And then it's better, like I said earlier, discard the first 2 ml, even if you've done multiple punctures, and take a fresh syringe, and this will avoid maternal cell contamination. Now, there are some rules you need to know. If you've got a female fetus, there's a higher chance of fetal cells having maternal cell contamination, because sometimes the maternal cells get confused. So you can even have a false negative fish, because actually speaking, the maternal cells were analyzed and not the fetal cells. So this has been reported in almost up to 7.5% of trisomic fetuses. And sometimes you can have a mosaic pattern. So even if the fetus is abnormal, because of a mix of normal maternal cells, you may have a mosaic pattern. So these are certain counseling things that you have to do. And unfortunately, by looking at the amniotic fluid, you cannot judge whether there is maternal cell contamination. Even if there is RBC or there are no RBCs, you have to do the MCC test. The only place where you do not need to do this is if you're looking for an X-linked disorder, and of course you've got a male fetus, then the maternal cell contamination is not important. Or if the recessive disorder is acquired from the father, then again, you do not need to do a MCC test. Is not important in that sense, because the mother cells will be normal. Now, the other problem that we commonly face is mosaicism, especially in CVS. We know that we can get a mixed cell line, and sometimes you need to differentiate a partial mosaic from a a confined placental mosaic from a true fetal mosaicism. And the only way to get out of that is to repeat an amniocentesis if you've got a mosaic cell line. If it's a true mosaic, then these fetuses are at high risk for fetal growth restriction and unknown pregnancy losses. So these are some of the indicators. You may have cysts in the placenta, and these could tell you that there could be confined placental mosaicism, which are common in trisomies 2, 3, 7, 8, 9, 16, and 22. So the only way to get out of it is to do amniocentesis. Now, finally, coming to a very, very important issue, all the gynecologists or the clinicians will tell you, but this is an invasive test. And even the patient is made to worry that do an NIPT at 10 weeks. We don't need to do an invasive test. And there's a complete myth around this. And I must share, and I'm sure a lot of people do know this. This is Ranjit Akulekar's study, which has broken this myth in 2015. And he did a meta-analysis analyzing the complication rate of CVS and amniocentesis versus a background risk. So the overall risk of a CVS was 2%. And amniocentesis was 0.81% compared to a background risk, which these fetuses would anyway die if you don't do a CVS or an amniocentesis, which was as high as 1.8 and 0.7%, because you must remember these are high-risk pregnancy situation. So the final risk is as low as 1:500 in a CVS and 1:1000 in an amniocentesis. So when you actually tell the parents that your risk is so low, and the wealth of information that you get, as I said earlier, the mother is not coming asking you that is my baby having Down syndrome? Mother wants to know whether the baby is normal or not. In fact, there are a lot of people, including me, who think that if I was pregnant, I would rather have an amniocentesis rather than going into it as a blind man, not knowing what the genetics of my baby is. This is another very important study done by Azma Khalil, who recently published this meta-analysis in October 2020 of the fetal loss rate in twin pregnancies. And very similar to what was published earlier, this, if you see the fetal loss rate with amniocentesis in a twin was 2.3%, and CVS was 2%. So very similar loss rates. But if you see that there was no amniocentesis done and no CVS done, then the background risk was very high, leading to a final loss rate of as low as I said earlier, 1:500 to 1:1000. And of course, in a monochorionic pregnancy, the risk was slightly high. But the conclusion is that the risk of fetal loss for both these procedures is much lower than what has been propagated. And therefore, these procedures have gone into disrepute. And I also feel the same, that the complication rate of even a CVS is much lower. Now, these are some of the rare complications. I've yet to see, maybe I've seen only one in the last 30 years of a spontaneous abortion following a CVS, but theoretically, there's a 1% risk which has been reported. You may get a little bit of bleeding, a little bit of amniotic leak. And infection, of course, doesn't happen because we cover with antibiotics. There are no limb reduction defects or any other abnormalities that we see with CVS today, because most of these procedures are done after 10 weeks. And even if you look at amniotic fluid, the mosaicism that you see with CVS is very, very low. So, of course, it does have a lower cell mosaic complication, but it is done at a later date, 16 weeks, and sometimes there's not enough time because you know that our PCP-NDT laws and MTP laws do not permit termination beyond 20 weeks. Now, if you see the risk of leak following an amniocentesis, which has been reported as 1 to 2%, the prognosis is much better following a procedure than it is with a spontaneous leak. So most of these fetuses will come out of the risk period and they will do well. So I think that's very, very important that you counsel your patients and the gynecologist. Now, what are some of the risk factors which you should look for? As I said earlier, if you're going to do multiple aspirations than that, so you need to train yourself very well. If you've got a lot of bleeding during CVS, then you need to counsel the patient to be on bed rest. Younger patients have known to show more complication. Gestational age below 10 weeks, of course, we don't do it. And here is one point where I have seen one complication is where there were multiple fibroids. These patients do have an irritable uterus sometimes and can go into a spontaneous abortion. At most other times, a uterine malformation can also increase the risk of a complication. If the mother has had a bleed in the immediate past week, then it may be better that you delay the procedure. And of course, if there is fetal bradycardia, then we don't do the procedure, but we delay it by 1 week. Now, finally, to conclude, the other aspect of the amniocentesis is an amnio infusion, and very rarely do we need to do it, especially now when we have such great neonatal management. In the early days, we used to do it for early onset IUGR, and now we do it only prior to putting a shunt at times when you have a fetus with a posterior urethral valve. And you can see here, this was a fetus with the marked posterior urethral valve. We gave an amnio infusion. We inject about 500 to 1000 ml of ringer lactate and take the MVP beyond 5 to 8, and then we do a proper therapeutic procedure. It could be a shunt, or as in this case, we did a fetal cystoscopy here with our help of Vivek Krishnan from Cochin, and we did a fetal cystoscopy, and this fetus is doing well now. So prior to any procedure, you need to do a diagnostic procedure and also amnio infusion at times to help facilitate most of these procedures. So that's the posterior urethral valve, and that's the laser, and this is the post procedure. You can see see that the liquor has improved and the fetus bladder has collapsed and is doing well. Many of these procedures are also required, especially if you're doing a twin pregnancy with one fetus having SFGR. If you're doing a bipolar quadri, then you may need to do an amnio infusion in the smaller fetus before you attempt to catch the cord. As you can see here, we are attempting to catch the cord. So it's very important that you have good amniotic fluid around that fetus. And then if you have polyhydramnios, sometimes, especially in a situation like tracheoesophageal fistula, bowel atresia, as you've been hearing since morning, or TTTS, then at times when you're close to term and you just want to prolong the pregnancy and avoid premature delivery, you can do a reduction amniocentesis to reduce the maternal discomfort and the early chance of rupture of membranes. The procedure is essentially the same. You connect the connecting cannula and you aspirate about a liter or so of fluid. And then, of course, if it's something like TTTS, then you do a final therapeutic procedure. In this case, of course, we did fetoscopic laser coagulation. So the take-home message is, what I want you to take home today is that these are very, very safe procedures. Their complication rate is very, very low, and you should not get scared to do either an amniocentesis or a CVS, and also counsel the patients accordingly, especially if they are necessary in given situations. You must not do something like an NIPT if you've got a nuchal combined screening, nuchal edema, and there's no evidence of trisomy 21. What's most important is that there should be correct anatomical placement of needle. And like I said earlier, you need to train yourself, go to a teaching hospital or with some dummy, you try and target and most radiologists are fortunately very good at this. Very important to avoid vascular injury of any form. Do not target the uterine artery, the iliac arteries, etc. And the moment you have fetal distress, please stop and ask for help. Thank you for a very patient hearing, and thank you, Sonobuzz team, again for inviting me to give this talk.
Thank you, Chander. That was really excellent. We have a couple of questions, if you could answer them, please.
Yes, of course.
Yeah. One is a simple one by Baldev. What gauge needle do you use for CVS and amniocentesis?
Oh, so yeah. So I use a 22 for amniocentesis, and I vary between 18 and 20 depending on the access. If it's a very obese patient and I'm not sure of getting good sample, I take 18. Otherwise, I take a 20G spinal needle.
Okay. All right. He is asking another question. Suppose, what are the immediate complications, and do we need to admit the patient after the procedure?
No, we don't need. These are OPD procedures, and we don't need to admit. I told you the complication can be just a bleed or a leak. These are the two complications. But if you keep the patient for observation for at least half an hour and 1 hour, you will immediately know whether you're dealing with a complication, and then you can just send them home or to a nursing home to rest for 2 days.
Okay, thanks. Abhishek has asked, do we have to know the sex of the fetus before CVS and amnio?
No, of course not. But if there are some provisions in the PCPNDT law, and I think Sanjeev and other people are better equipped to answer that, especially in situations like ambiguous genitalia, congenital adrenal hyperplasia, some neurological diseases where the gender is important. I think there are provisions to know the gender.
Okay. All right. Thank you, Chander. That's fabulous walk through all the intervention that one can do and that you do so well. So thank you for being with us.
Thank you.
And goodbye. Yeah.
Thanks
very much.
Bye.
Thank you. That was just a wonderful lecture by Dr. Chander Lulla. Covered almost all interventions with regards to CVS and amniocentesis, also how he does them, the technique and the complications. We now have Dr. Nitin Chaubal back again.
Again, thanks, Sanjeev. So this is the last lecture as such for the Sonobuzz. We had a marathon session for 8 days, and I really appreciate the efforts taken by the entire Sonobuzz team. So we come to something which is not very difficult as compared to the CNS talks which we heard in the morning, and we'll talk on fetal thorax. But it's a very, very important thing to understand. Now, if you look at the development of the lung, it starts from a very early stage and goes on not only till late trimester, but even postnatally. Even postnatally, we have factors like the surfactant coming up. So it's very important to understand that. And depending upon where a particular development stops, we can have different types of anomalies, as we'll see later on. So as per the ESOP guidelines, nowadays when we do NT scan, we look at the symmetry of the lung, and of course we look out for any effusions or masses even in the first trimester. So typically when we look at a 4-chamber and a 3VT, we also glance at the thorax or the fetal lungs on either side. And even in the first trimester, 12 weeks or whatever time you do, it's a good habit to, of course, we need to look at the stomach and try and identify the diaphragm as well. So when we come to second trimester, of course, we typically, when we look at a 4-chamber, that is the time we look at the symmetry of the lung on both sides, the echogenicity of the lungs on both sides, and try and see whether there is any abnormality as such. Now, if you look at the reflectivity of the lungs are slightly hyper-reflective as compared to the surrounding lever, and of course, that's the dome of the diaphragm. So whenever we look at lungs, we can now use, So nowadays we can use high frequency probes like the linear probes, which a lot of machines have, and we can see the appearance of the lungs in much better way, and we can also appreciate the diaphragm in a much better way. Now it's a good habit to look at not only the outline of the diaphragm, but also to look at the movements of the diaphragm. And normally both the domes of the diaphragm have to move synchronously. So that's a very, very important thing which we need to observe, and we'll see why. So nowadays we have good tools to look at blood flow in the lung. So we can see not only the main pulmonary arteries of the veins, but we can really go right up to the periphery of the lung and look at the vasculature. We can use techniques like the glass tube, etc., to reconstruct the blood flow in the lung. We can now measure the lung volumes much more accurately with newer techniques like the Voxel. And this is very important not only in CPAM, but also in diaphragmatic hernia, as we'll see. Now, we need to understand a basic difference between axis deviation of the heart and a mediastinal shift. So normally we know that a heart is at a 45 degrees axis, and there can be a left axis deviation where the axis turns, the apex itself turns a little more toward the left, or there can be a right axis deviation where the apex goes towards the midline. Now, when you have an axis deviation, we always think of intrinsic cardiac anomalies. So typically when you have a left axis deviation, there are certain anomalies we think of, and when there is a right axis deviation with the line coming in the center, we need to think of some anomalies. Now, why I'm showing this is because as compared to axis deviation, mediastinal shift is a different entity in a way. What happens in mediastinal shift is that the heart still points to the left or to the right, and the heart gets shifted to one side. So if there is a mass, say, on the right side, the mediastinum will be shifted to the left, but the apex of the heart will still point to the left. And similarly, if there's a large mass on the left side, the entire mediastinum will be shifted to right, but the apex of the heart will still point towards the left. And why it is important is because axis deviation typically is associated with cardiac anomalies, whereas mediastinal shift is one of the hallmarks of a thoracic abnormality or a thoracic mass, and one of the whistleblowers, as we'll see later on. So what happens in day-to-day practice is we always don't make it a point to look at lungs specifically. So just like we look at 4 chambers, RVOT, LVOT, we do not look at lungs, though we are supposed to look at lungs. So there are some whistleblowers which make us aware that, okay, something is wrong in the thorax or in the lung. And the first whistleblower is a mediastinal shift. So here, for example, we can see that the entire mediastinum is shifted to the left, but the apex of the heart is still pointing to, it was shifted to the right, but the apex of the heart is still pointing to the left. And that's a classical mediastinal shift. And this is the first whistleblower that something is wrong in the thorax or in the lung. The second whistleblower is the appearance of the lung. So typically we said that lungs are slightly more hyperreflective as compared to the liver, but if the echogenicity is significantly different as compared to the liver, that's another clue that something is going wrong in the lungs or in the thorax. And of course, this can be a large hyperreflective mass, as we'll see later on. The third whistleblower are presence of cystic areas within the lungs. So normally we have uniform appearance of the lungs, but if you see cystic areas such as this, that's a third whistleblower that something is wrong with the lungs or in the thorax. The fourth whistleblower is the position of the diaphragm. So just to show you that normally, if you look at a diaphragm and the respiratory movements, the diaphragm shows a slight convexity towards the chest, and that's a normal appearance. If the diaphragm is flat, or if the diaphragm becomes convex towards the abdomen, that's another whistleblower that something is wrong in the lungs or in the thorax. And lastly, look at the movements of the diaphragm. As I said, that both the leaves of the diaphragm should move synchronously. That is very important. If you see a paradoxical movements of diaphragm, as you see here, you can see that one leaflet is going up, the other going down, one coming up, the other going. That is another whistleblower for a possible thoracic abnormality, classically, for example, in a diaphragmatic hernia. So as I said earlier, very often lung abnormalities are picked up, not because we are concentrating on the lungs, but because we see one of these 5 whistleblowers, which makes us aware that something is going wrong. So commonly, what do we see? We see obstructive problems, like for example, chaos or atresia or congenital overinflation, which is difficult to diagnose. We see intrinsic lesions like CPAM, sequestration or hybrid lesions. And then we have miscellaneous other things like diaphragmatic hernia, pleural effusion, bronchogenic cysts, neuroenteric, and finally teratomas as well. So we'll go through some of them. Now, chaos or congenital high airway obstructive syndrome is one common cause of obstruction, a common thing which we see in obstruction. Here, typically the obstruction is at a high level and the underlying cause is an atresia or a stenosis of the larynx or the trachea. Now, if this affects one bronch, someone is fighting.
Well, just wait for 1 moment.
Okay. Was that a Republic channel? Look like. Okay. So if one of the bronchus is atretic instead of the larynx or the trachea, then we can have one unilateral lung enlargement as such. So typically what happens in chaos is that both the lungs are enlarged, they're hyperechoic. As I said, the diaphragm becomes flat or it might show convexity on the other side. What we see is a fluid-filled trachea and the bronchi. Sometimes we might see even the tertiary bronchi, and very often we, of course, have hydrops. And very often we see this at an early stage. Now, this is thought to be because of a vascular insult which comes up during the development of bronchus or trachea. So, as I said earlier, that various abnormalities come up because depending upon the time of insult which happens in embryology. And typically here what happens is that beyond that, the distal bronchi becomes mucus filled and become dilated, and we see a white lung. So the entire lung may be white, or one lung may be white if the atresia is in a bronchus. So typically the heart becomes misposed, mid-posed, and mid-posed and comes in the center. And of course, very often by the time you see them, you might have non-immune hydrops coming up because of the obstruction of the veins as well as lymphatics, and very often you have polyhydramnios. So this is what happens. The entire trachea, which normally is of course seen but difficult to see, becomes fluid filled. Sometimes of course the bronchi and the tertiary bronchi become fluid filled. The heart sort of gets compressed, which is very often referred to as a mesocardia, and sometimes you might see increased vascularity in the lung field as well. And this is what happens to the heart. The heart really gets sort of squeezed between the two lungs, and you can see that ultimately this fetus would develop hydrops. So a good number of times when we see this, they develop hydrops, or if you follow them up, they develop hydrops, and you might have ascites, polyhydramnios, etc. Now, the chaos is very often associated with esophageal atresia and tracheoesophageal fistulas as well. And as I said earlier, that the prognosis is usually very poor. They land up with hydrops and very often in utero deaths or afterwards. And there are some, abroad of course, there are some treatments which are done postnatally, but overall the prognosis is very poor. Then of course we have intrinsic lung lesions where we have CPAMs or congenital pulmonary airway malformation. We have bronchopulmonary sequestration and we have hybrid lesions. And very often it becomes difficult to differentiate one from the other. Now, overall, if you look at echogenic cystic masses, the incidence is about 1 in 3,000. Now, CPAM typically is actually, they feel it's an hamartoma, it's a mesenchymal sort of changes coming up within the lung. Usually it is unilateral, but it can affect either any lobe or the entire lung or multiple lobes, as we'll see subsequently. So it's one of the most common congenital lung lesions, almost 75% of all lung lesions, and it is a hematomatous lesion supposed to be. And the pathology basically is that there is an overgrowth of mesenchymal tissue because of cessation of the bronchial growth at a very early stage, with an insult happening before 16 or 17 weeks of gestation. And one of the hallmarks of CPAM is that there's a communication with the proximal airways, though of course this communication may be abnormal. And of course, the diagnostic feature of a CPAM is that the blood flow for CPAM comes from the pulmonary artery, and the venous drainage also is from the pulmonary veins. So whenever we see masses like this, here for example, it's filling up entire one of the lung, and it's very important to look at the blood flow. Now, this is an old classification which was based on histopathology. A lot of people have given it up, but overall, I still feel that it's a good way of describing these lesions. It's a good way of prognosticating lesions, and therefore you can still use it. So typically, type 1 is multiple large cysts, usually more than 5 centimeters. Type 2 are multiple small cysts less than 5, and type 3 are microcysts, or they are solid cystic lesions, typically less than 5 millimeters. So that's an example of a type 1 CPAM, type 2 CPAM, and that's an example of a type 3 CPAM. So a lot of people don't believe in this classification, but I still believe that it's a good way of describing these lesions. So type 3 are usually solid, uniformly echogenic, or they can be very, very tiny microcysts. Now, as compared to CPAMs, the other pathology which we see is pulmonary sequestration. Now, here typically the lesions could be small. They are very often close to the diaphragm. They're very often sort of triangular in shape. And the diagnostic thing is, of course, a blood flow coming from a systemic vessel like the aorta. So these are solid echogenic lesions. They're thought to be of a pleural origin. And the difference is that there is no communication with the bronchial tree. And here again, we have a large sort of a sequestration, but the blood flow is coming from the aorta. So very often, as I said, they are located very close to the diaphragm. They could be infradiaphragmatic also. Most of the time, they are unilateral. They could be bilateral, and the blood flow is very, very important. And of course, very often what we have are hybrid lesions, where we have a component of sequestration and CPAM coming together. And actually on ultrasound, it is very difficult to differentiate between the different types of lesions very often. Now, so we very often we see them as supradiaphragmatic, infradiaphragmatic, and just now we had one case where antenatally we felt it is supradiaphragmatic. Postnatally, when the baby was born, on scanning, we felt it is infradiaphragmatic, but on surgery, actually it turned out to be intradiaphragmatic sequestration, which is a very, very rare thing to happen. So look out. So it's a very important thing here is to look out for the blood flow, whether it's coming from the pulmonary vessels or whether it is coming from the aorta. And nowadays, of course, with good machines, that is very easy to do. So with sequestration, we can have other anomalies like diaphragmatic hernia, vertebral anomalies, congenital diseases, pulmonary hypoplasia, of course, colonic duplication, etc. And therefore, a thorough search is very often required. So as I said, that very often, almost sometimes 50% of these lesions could be hybrid, and it is very difficult to differentiate between this time. So typically, most of these lesions, they increase till about 24 weeks or 26 weeks, where they reach a peak around that time and then gradually decrease. That's very important. And all of them do that, and therefore, very often the composition is not a very, very important issue. So we all know that what we look out for whenever there is CPAM or pulmonary sequestration is the presence of hydrops. So once you see hydrops, then of course we are worried about the outcome. And typically, when you see progressive hydrops coming up in the second trimester, then of course the prognosis may be bad. Or in some cases, once there is a hydrops, or then we should or may think of doing an intervention as well. So when you counsel the patient, this is very important in CPAM. There is no significant association with chromosomal abnormality genetic syndrome, so it's reassuring. And less than 20% develop hydrops. So CPAM, no hydrops, very good survival rate, and almost 50% resolve antenatally. With hydrops, the mortality goes up significantly to 90 to 95%, and some of them you might have to intervene in utero. So just some examples. This year, 2020, we had this lady who came on 1st October. That was a smallish sort of a CPAM. We followed up. She came from a long distance and she came directly in December, and the entire lesion has totally disappeared. This is another lady. She had a very large lesion. In fact, it was occupying the entire lung, and someone somehow suggested a termination, and she came to us. It looked like a hybrid lesion. There was some blood flow coming from the aorta. So we reassured her and we said, okay, we'll follow it up. There were no signs of hydrops. There was no hydramnios. And we followed it up. Subsequently, it went on reducing in size. And third trimester, it totally disappeared. The child was born. We did a CT scan after that, and there was no lesion. The child was asymptomatic and therefore left alone. And this child very often comes to us on his birthday. So now some measurements we do very often in practice. There are newer measurements which have also come up, but this is a good way of sort of prognosticating. So what we do is we do the CPAN volume, and then we take a ratio with the head circumference, and we derive what is known as a CVR. And again, these are very easily available on the net, these calculators. So if the CVR, of course, is low, it's a good thing. If it is large, more than 1.6, then we need to keep a closer watch. So if you have a CVR of more than 1.6 and you see large cysts in the malformation, these are the feta who require a very close follow-up and subsequently may potentially develop hydrops, or you might have to intervene. So typically that's a figure which is good enough for counseling. Some people like to take volume of the lung and compare it with the weight, and this is also can be done. So what we are worried about in CPAN and large bronchopulmonary sequestration is the development of hydrops with ascites coming up. So most of the literature says that even if you have a mediastinal shift, that doesn't change prognosis. Even if you have mild, moderate hydramnios, that doesn't change prognosis. But once you have hydrops, that is accumulation of fluid in other places in the body, that is when things you need to worry. Or when you have such large cysts like this, which are filling up the entire lung, again, here we need to keep we need to counsel them about potential coming up of an hydrops. So here's an example at 29-30 weeks. This is last year. We had a CVR of 1.2, which is little unusual because usually by 29-30 weeks we start seeing them regressing. So we said, okay, there was no hydrops, so we said, okay, we'll watch. But after 1 or 2 weeks, the CVR increased further, reached almost 1.6. So we gave them steroids because very often with steroids we can see a reduction in the size of a CPAM. But it continued to increase, and before hydrops could set in, we thought we will put a shunt from the cyst to the amniotic fluid, but the patient had come from a long distance and it was difficult to get the shunt immediately. So what we did is we aspirated the larger cysts or the macro cysts, and fortunately a good number of them were communicating. So after aspirating 2 cysts, the size of the lesion actually decreased in front of our eyes, and subsequently on follow-up at 36 and 37 weeks, the CVR, which had gone to 1.6, dropped to 1.2 or even 0.6. So this child was born in Thane, and subsequently a CT scan was done, which showed a small lesion. And because the child was a little symptomatic, they did a surgery, and but subsequently the child has done significant, very well, and is almost, I think, 1 year now. So we can also put, of course, shunts from large cysts into the amniotic fluid if you see that eye drops is developing. Now, what happens is very often if you're doing an interventional procedure, you don't know whether these cysts are communicating or non-communicating. If they're communicating, it's good for us, So what has been suggested is that once you puncture the cyst, you can put some contrast, ultrasound contrast like Definity or Sonoview, and then see whether the cysts are communicating. If they're communicating, then our interventional procedures can become good. So if you have large macrocysts, then there is an option of doing aspiration or putting up shunts. But if you have microcysts or solid lesions, then again, then people have done laser ablations, or people have done also percutaneous sclerotherapy. Honestly, I have not done anything in solid lesions so far. What about sequestration? Again, no effusion, very good survival, and almost 50% resolve, but a good number of them would require sequestrectomy after birth. But with effusion, again, the prognosis is bad. So if there is a pulmonary sequestration with effusion, then it is advised that we drain the fluid or put a shunt from the pleural cavity into the amniotic fluid and burn the feeder vessel with laser or with an RFA. And this is supposed to have a very good effect, and that's I've taken it from one of the journals where they have done a laser for the feeder vessel. So this, of course, benefits the fetus significantly in those who are developing eye drops, and the lesions is supposed to regress. Now, very, very important message here is that even if you see the lesion regressing in the third trimester, this does not match the actual regression, because a good number of these lesions become isoechoic in late pregnancy. It might be difficult for you to pick up, and therefore it is very important to investigate after birth. So there are two schools of thought. Some people like to do a CT scan in almost all patients, and in some pediatric surgeons would like to do it only if the fetus or the newborn is symptomatic. So I would say if the newborn is symptomatic, then definitely one should do a CT scan, because you are not going to see it easily on X-ray, or you are not going to see it on ultrasound neither after the baby is born. So another very important thing is that when you counsel, almost about 10% of CPAMs can potentially develop pleuropulmonary blastomas. So this also has to be kept in mind when you do the counseling to the patients. This is of course in CPAMs and not so in sequestration. Then we see other thoracic abnormalities, and one common tricky sort of a situation is when you see that both the lungs are showing increased reflectivity. This is a slightly dicey situation. First of all, with the higher resolution probes, very often you feel in almost all babies, all feti, that the lungs are hyperreflective. So you should use the right sort of a setting. But here we had both the lungs hyperreflective as compared to the liver, and we had other markers of down. We had a nuchal fold which was abnormal. We had nuchal prefrontal edema, and we had absent nasal bone. So we did an amnio, and this was a trisomy 21. So both lungs hyperechogenic is a marker, can be a marker of Down syndrome. It can be also a marker of fetal infections. Then this was a very odd case which we had. That was the right lung, and in the upper lung we saw this tubulocystic areas there. And initially, of course, I didn't know what's happening. Then, of course, when that happens, we switch on color, and we saw a large sort of a vascular lesion there. And you can see that the pulmonary veins are grossly dilated, and the right side of the heart is huge. So that's a vascular malformation. So this was some years back, and I consulted Dr. Suresh, and we decided to do an RFA for this lesion. But as luck would have it, and as happens very often in our situations, the lady sort of disappeared from the scene, and she was just lost for follow-up. Then, of course, we see pleural effusions. They can be a part of non-immune hydrops. So here, for example, we have a pleural effusion on one side. We have a hepatomegaly. We are investigating this fetus right now for potentially genetic abnormalities, infections, or even metabolic disorders, because there is an hepatomegaly associated. And then we'll see what to do. This was another one where we suddenly saw pleural effusion coming up at late at 28 to 29 weeks. There was no underlying cause. So we did investigate the mother thoroughly. We did a pleural tap and investigated, and there was nothing found. So this was an idiopathic pleural effusion. Now, if you see an idiopathic pleural effusion, then again one can tap it or put a shunt. But typically, if there's a large effusion, then it is wiser to tap it before birth. So before the child is born, you should tap the pleural effusion and then send for delivery, so that during the birth, usually the babies will not have any problems. Then, of course, diaphragmatic hernia. Diaphragmatic hernia is a different topic, but I'll just go through some very important slides. And of course, the most important thing is what makes us alert, or what makes us think that there is a diaphragmatic hernia, is the presence of stomach in the thorax. So here we have stomach in the thorax, and as I said, the second whistleblower is a shift of the mediastinum. And when we see diaphragmatic hernia, we need to look at contents, whether the liver is up, and we need to measure the contralateral lung volume. That is very, very important. And this is about 1 in 3,000. Now, the contents of the diaphragmatic hernia are very important. Besides the stomach, whether the liver is up, whether the vessels of the liver are up. Here, for example, we can see that umbilical vein was going up and right draining into the superior vena cava. Here you can see that the bowel loops are herniating within the thorax. And of course, a very important prognostic point, therefore, is the presence of contents, especially the liver, whether the entire liver or part of the left lobe is up. That's very important message. And as I said, that another clue towards diaphragmatic hernia are these paradoxical movements of diaphragm. So if you see that both the leaflets are not moving together and they are moving in an opposite direction, so that's a clue towards diaphragmatic hernia. Now, this is very important, especially when you don't see a stomach and you have intestines which are herniating. They can be very difficult to identify. You might just see some hyperreflective areas, you're not too sure, and that is the time when paradoxical movements of diaphragm are very, very important for diagnosis. And this you can see even at an early stage. That's an early fetus, about 15 weeks, that's the stomach there in the thorax, and again we can see paradoxical movements of the diaphragm. The other important sign is the upturned superior mesenteric artery. So here we have diaphragmatic hernia. The stomach is there, of course. A part of the liver was herniated here. But what you can also see is that the superior mesenteric artery is pointing towards the thorax. So normally we know that the superior mesenteric artery, when it comes from the aorta, would be pointing caudal towards the fetal bladder. But here it's pointing up. And this can be picked up at an early stage also. It's a very, very reliable sign of bowel hernia. So a very important thing once you look at diaphragmatic hernia is to look out for other abnormalities. So here, for example, we had an AVSD, again picked up early, diaphragmatic hernia, of course, absent nasal bone, prefrontal soft tissue edema, that was a trisomy 18. And here again, a nuchal lucency abnormality, picked up diaphragmatic hernia at a very early stage with transvaginal probe, and this was a very rare mosaic trisomy 16. Which is, as Chander was saying, so sometimes you come up with such odd diagnosis after doing further evaluation. So typically when you have an abnormal NT, besides doing a microarray, also follow up this feti for diaphragmatic hernia, which could present a little later. Right-sided diaphragmatic hernias are not common in practice, but we might see them occasionally as well. So again, for prognosis, besides the contents of the hernia, we do have some measurements which have been there for quite some time. One which is very popular is the LHR, or the lung to head ratio. There are new measurements which have come up. We can also do the observed to expected LHR, and if this is more than 45%, it is good. We have quantitative lung index which can be done. And then people have done measurements of the part of the liver and the part of the herniated contents, and the part of the normal lung, and come out with newer indices as well. Now, one of the important things we need to remember, besides the volumes of the lungs, contralateral lungs, and the contents, is that what changes the prognosis is not only the maldevelopment of the lung itself, but also the pulmonary vascular hyperplasia. And therefore, ultimately, what very often these babies die of is pulmonary hypertension. And therefore, people have tried to look at this by measuring the pulmonary vasculature with volume index or with 3D power, and measuring the vessel sizes also of the pulmonary arteries. We can always use the MRI whenever there is a doubt or you're not sure what are the contents. Typically, that's an upturned liver. And here you have a liver down. As I said, position of liver is a very, very important prognostic point. The surgery itself for diaphragmatic hernia is not very difficult. As I said, that's the defect there. That's the excision of the sac, and that's a primary repair. What changes the prognosis is the presence of the pulmonary hypertension. So here we had an fetus where at 28-30 weeks or so, we saw that there was an intermittent shift of mediastinum. The mediastinum was not permanently shifted. So we said, okay, we should be alert. And since now it's come up late, the prognosis will be good. And rightly so, when the baby was born, there was a left-sided diaphragmatic hernia which was repaired. And this child, in fact, went home very early from the neonatal ICU and has done very, very well. So it also depends upon when you pick up the hernia. If you pick it up late, then the chances of lung development being good are very, very, very high. So in some centers, of course, abroad, balloon tracheal occlusion is done for diaphragmatic hernia, where you do a fetoscopy and then insert a balloon, and just before delivery sort of deflate the balloon, which is supposed to be even more trickier than actually introducing the balloon. Then we have bronchogenic cysts, which are typically large or small cystic areas very close to the mediastinum. This is a large bronchogenic cyst, and these are thought to be a sort of foregut duplication cyst, and very often they have a very good outcome. So that's another bronchogenic cyst. Then we can have neuroenteric cysts. These are typically in the mediastinum, posterior mediastinum, and very often they are very close to the spine, of course, and you can have associated abnormalities of the spine as well. So neuroenteric cysts as compared to bronchogenic cysts are because of incomplete separation of the notochord from foregut. The cysts contain both the gastrointestinal and the neural elements, and there is a connection with the meninges as well. Then we can have mediastinal teratomas. This is one of our very old cases. There was a large mediastinal teratoma. We can see a lot of calcification, and of course, when the pregnancy they present to us, there was already an hydrops there. So another thing is, when you see that the mediastinum is shifted, but you do not see any mass as such, and you do not see any intrinsic cardiac anomaly, then we need to think of pulmonary agenesis or a lung hypoplasia. So shift of mediastinum to one side and no mass seen on ultrasound, and the cardiac heart is normal, we need to think of pulmonary agenesis. And here again, we can use MRI as well. So this is a nice case which Dr. Suresh has given me. So here you can see that there's a shift of mediastinum to the right. The apex of the heart is still pointing to the left. And as you can see that there is no mass on the left side, which is pushing the heart. So whenever this happens, we need to think of pulmonary hypoplasia. And now if you look at the vessels, the left pulmonary veins are draining rightly into the right place, whereas the right pulmonary vein is draining directly into the inferior vena cava. So that's a classical scimitar syndrome. So all in all, as I said, it is very important to look at lungs. Very often we sort of neglect the lungs for some reason, not for some reason, but because we don't specifically look at lungs. But as I mentioned, there are 5 or 6 whistleblowers we need to be aware of. And the other thing is that very often in most of the lung pathologies like CPAMs or bronchopulmonary sequestration, the prognosis is very good, and it's very important very often to sort of reassure the parents that the chances of a good outcome are very high. Thank you so much.
Thank you, sir. That was really wonderful. We have a few questions, sir.
Yeah.
One is from Paresh. How to differentiate right diaphragmatic hernia and right eventration of diaphragm?
Very good. So this can be a problem, and so what we need to do is, of course, look at the margins of the diaphragm. So very often with the high resolution probe, you are able to look at the margins of the diaphragm, and that can help you in this. And secondly, of course, if you see a paradoxical movements of the diaphragm, that would confirm an herniation as opposed to eventration.
Zarina is asking, is there any particular feature to differentiate type 3 CPAM involving the entire lung from a unilateral bronchial atresia?
No, and really speaking, we cannot differentiate between the two because in both the cases we are going to have unilateral hyperechoic lungs, so it is not possible. But usually, if it's an atresia, then it may progress faster as compared to CPAM, and the volume could be much larger as compared to CPAM. And sometimes you might have a diaphragm being flattened on that side. You might see bronchi which are fluid filled, which you would not see in a large CPAM. So that would be a differentiating feature.
Okay, sir.
But it can become difficult, yeah.
Okay. Sunil Goyal is asking how to measure liver size of fetus. Should we do this?
So liver size, we normally don't do that. As I said, there are some articles which have quoted liver sizes, but I'm not really familiar with that.
Okay, so
but you can try, yeah.
Okay, Sonal is asking, is it safe to use SonoView in fetal USG in problem-solving cases? What is the dilution? Because you mentioned in one of the...
So what I mentioned is the local injection. I didn't talk about intravenous. Yeah. But people have used intravenous SonoView also, and I suppose it is safe. So that is not a problem. But what we talked about is not IV. We talked about local, and local is absolutely safe anywhere in the body for anyone.
Okay, so Dhaval is asking, can you just brief us a little more on the type of or size of shunt you put in the fetal lung cavity?
So actually, nowadays there are a lot of many. I've not done honestly many shunts. One we have done in the past. Most of these have been tappings. But nowadays we have very new shunts which have come up, and I can share the product information if you want. If you can give me the email address, which are very easy to introduce. They're very small, and they don't easily come out, and they have sort of a valvular mechanism whereby they don't come out. So I've got some product information with me which I can share if you give me the email address.
Okay, sir. So Paresh is asking, CVR is applicable to CPAM and PS both, or only CPAM?
Yeah, for both. So very often it, as I said, a prognosis for both is more or less the same. The outcome is more or less the same. So we use it for both.
Okay. So I think we've reached the end of these question answers, and thank you very much. We still want you to be around, as you know. So you could just, if you, Amit, can you just switch on the slides, please? I can speak for Dr. Chaubal, who's been just absolutely a master at this webinars. And I just curiously asked him, like, how many webinars did you do, sir? And he said, I have done, he put a very conservative estimate of about 100, but I believe he's done 150. So that's 150 webinars or lectures given in 300 days, which is itself just like absolutely fabulous. So thank you, sir. You were like the first name we scratched across on that list. And we have Alpana Joshi, of course, who's a new entrant, but she has sort of stormed the YouTube channel of ours, and I think her videos have got more than 100,000 views, which is itself wonderful. We have, of course, Asif Momin, Dr. Ashok Khurana, and Dr. Chander Lulla, who always been with us at every event. Their lectures of all, including Dr. Chaubal, Ramurthy, they span across organizations, across societies, whether it is fetal medicine or whether it's radiology channels and gynec ops, because the primary focus, of course, is teaching. And I leave, since Srijita has just joined us from Kolkata, I will just leave a description of Dr. Utpalendu Das to Srijita. Please, Srijita, you go on.
Okay. Like Professor Utpalendu Das is actually presently the head of the department radiology at IPJMR and SSKM Hospital, one of the leading teaching hospitals in Kolkata. He was the past president of IRA West Bengal chapter and also Central Council committee member. And he has his teaching experience of over 35 years, and his expertise and skill in the field of USG is just unmatchable. He's one topmost name as a teacher in Kolkata, not only Kolkata, outside Kolkata also. Especially his US guided interventions, especially the most difficult ones, with so much ease and confidence, the way he performs, it's a real treat to see that. And I have been his student too, and I would say the best thing about Utpalendu sir is his approachability, right? From an associate professor level to the junior most resident, anyone can come up to him with any problem at any time, and he's always there with a smiling face. And one more thing to add beyond his academic qualities is he's a wonderful poet. He can just make a poetry out of anything, describing anything impromptu at the moment. We love him. Thank you so much. And
thanks, Leela. Thanks for that. So these are our 11 ultrasound educators of 2020. We will continue this in 2021, where we will invite these 11 and also, of course, have a couple more to add to this growing list. We now have a final session of Dr. Nitin Chaubal, which is the quiz contest. And across these 6 days, we've been giving prizes out to the fastest finger first, because we thought that's the best and easiest way to approach this. And Dr. Chaubal has made a long list. He's made a list of 16 cases, which he's going to wrap up in like about 35 minutes, I believe, sir, 40 minutes. And he's decided that he is going to give every question and every correct answer a prize. So we're going to have 16 prizes for the person who enters the correct answer in the chat box. So it's the same way, sir. One question, you put up the slide, people will answer.
And you have to.
I will tell you when I've got the correct answer. Sir.
Correct.
Because
so
you've shared.
You take a call on the correct answer.
Yeah, the one which comes in the chat box with a name. All of you, please put a full name. If you have a full name or or an email ID, only then can I sort of give the prize to you, or it goes to the next one whose name is there.
Okay. So are we okay?
Yes, sir.
Okay. So I think we, in the last 8 days we had
I'll just have 1 moment. Just stop everybody off. 1 moment.
okay.
I think that's good.
Yeah. So in the last 8 days, I think we covered ultrasound. We had marathon sessions going up to 12:30 in the night. So and so what I'm going to do is sort of I put this quiz where we cover not only fetal medicine but also other aspects of ultrasound, and it's more like a fun game. It's nothing, But and most of these things are very easy. But what we need to do is fastest finger. So you need to type out the answer very fast and write your name. And the judging will be done by Sanjeev because I don't have any control. And as he said, we have 16 prizes to be won, which is a huge thing. Okay, so let's start. And how much time do we give them, Sanjeev? Or as soon as you get an answer.
Yeah, 20-30 seconds roughly, or if we get a few answers coming in.
So you tell me when to go to the next one. Okay, so the first.
Yes, we can start.
So first is a 20 weeks fetus, and these are the pictures.
People can start typing in the answers.
If you have attended UltraFest in the past, this was shown earlier.
Yes. We had done that as the Masters series,
correct,
right?
Correct.
You and Dr. Suresh. Yeah, I remember this.
So are you getting answers?
I'm getting, but I'm still not got the right one.
Okay. So I think I should start giving some clues.
Yeah, I think you give a clue, sir.
So what?
Some people are close, yeah, but
Okay. So what are we seeing here? I mean, we are obviously seeing dilated kidneys. We are seeing a bladder. We are seeing this sort of posterior urethra dilated. But is that the end? Are we seeing something more beyond that? And that thing doesn't show color. And that thing we are not supposed to see. So I think enough clues, Sanjeev.
Yeah. We've got the answer, sir.
Okay, great. So who is that?
I'll have to really scroll through. Pradnya has answered this as megalourethra.
Fantastic. Yes. Congratulations. So what is very unusual is if you see an obstructive uropathy, we need to go right up to the cause. So here we feel that it's a posterior urethral valve, but when we look at this structure, there's a structure there, and of course that's the penis, and it is not a cord because there's no color flow, and that's a congenital megalourethra. That's the fetus at birth. And what is this? Is basically caused because of an abnormal development or hypoplasia of the penile erectile tissue, and it's a very rare malformation, but one we need to pick up because the prognosis is not very good. It's a bad prognosis. If someone has answered anterior urethral valve, you can partly be correct, but here
Snigdha Bhatt has answered urethral meatal stenosis.
Not really. Anterior urethral valve is another entity which can mimic, but there the erectile tissue itself is not affected. Here it's very thinned out, and therefore it's not a good thing to happen. That's good. Congratulations to the winner. Okay, that's the second one. That's an NT scan. This is not a very good NT picture, but I put it in that way because I wanted to show you the clue. And this is just for normal comparison. So your time starts now. Even if you give the sign and a closest differential diagnosis, that would be good.
I think we've got the answer, sir.
Fantastic. Who is that?
I think it's Bhumika, sir.
Okay, great. So what is she answered?
DWMC.
Very good. So I mean, the what we are seeing here is an increased IT. So what we were focusing all these years is a decreased IC or obliterated IT, which is a sign of spina bifida. Here we have an increased IT, and what is very important and a teaching point, which I think I've done in my workshop, is now we always take axial views of the head in the first trimester besides the sagittal view. And we can see again here the dilated fourth ventricle. And if you look very closely now, I can see the communication and I can see a downward slit of the roof of the fourth ventricle, which all favors the diagnosis of Dandy Walker. Another very important thing here is that in the first trimester, we are seeing ventriculomegaly. And there are no well-defined criteria for ventriculomegaly, but people have taken various measurements like the length ratio, area ratio of the choroid plexus to the ventricles, as well as the length and area ratio of the choroid plexus to the BPD. Ravi Shaw has done that. So there are no definite criteria for ventriculomegaly. So two important teaching points here in this case. One is an increased IT, as she has pointed out, and secondly, of course, ventriculomegaly, and the fact that you should now routinely take an axial view. So, I mean, a good number of you must have heard Simon Meagher's lectures this time. That's a very important thing, which we were not including all these days. So, BPD and axial view of posterior fossa is becoming a must in the first trimester. Two important teaching points.
I think Bhavin Patel has answered this first. I'll check again, but I think he just came in.
Tell Bhavin he should not be answering. Okay. Okay. Fine. 26 weeks fetus. I didn't hear Alpana's talk this morning. I was having my lunch, but maybe she covered this. That's the fetal abdomen, by the way.
So we've started getting the correct answer.
Fantastic.
So Amit, Manjusha, and Atha, three of them have answered.
Okay, so you're going to split the prize, or that's up to you.
I need their surnames first. They're not giving their surnames, so I'll have to search on the first.
So that's the fetal volvulus, bowel volvulus, which is of course not very common, and this is very commonly associated with fetal atrasias as well as intestinal malrotation. And if we see it at this stage, like 26 weeks, the prognosis can become guarded because you can have a gangrene of a large part of the intestine. But sometimes we see it in third trimester. We have had feti with third trimester the volvulus who have done subsequently well. And this is very often again referred to as a whirlpool sign or a coffee bean sign in the fetus. Okay, so we go to the next one. The syndrome. You have to name the syndrome.
Case 4, right?
Case 4. Case 4. I think PGs would be able to answer this very fast.
We're still waiting, sir.
Okay.
Nobody's answered as yet, sir.
Just a clue. This is
We got it again, I think, yeah.
Who?
So again, it's Amit and Kiran. Amit, we need your full name. Amit, can you type in the chat box? And Kiran too, please. Can you type in the chat box right now? Yeah.
Okay. So that's a left renal fossa. You don't see the renal kidney at all, and that's a transrectal ultrasound with a dilated submanual vesicle, and of course the underlying there is always a ejaculatory duct obstruction also. So this is a Zener syndrome or Zener syndrome. That's a diagrammatic representation. So we have ipsilateral renal agenesis with ipsilateral ejaculatory duct obstruction and large submanual vesicle. We have seen a good number of these patients, and in fact we had a doctor who was very asymptomatic throughout his life. And after he got married, he had a painful sort of ejaculation. He had then he had dysuria, and then we came to know that he has this problem. So all this time he was never aware that one of the kidney is absent. So that can happen. Okay, and this of course happens is because there is a common embryological origin of the mesonephric duct. Very good. Another one. Here, even if you give me a short form, I'll be happy because even the long form I don't remember very often. Not the right thing to do on Sunday afternoon, right?
Yeah, so we have 400 people here.
Very good. Fantastic. That's an easy one. Only thing is the name. But as I said, even if you give the short form, it's good enough.
Yes, we've got a part of that syndrome which has come, sir.
Okay.
I think that's fair. Yeah.
So,
So Avanika Nalia has written Wunderlich syndrome.
oh, very good. I think that's good enough.
Yeah.
So, I just said, even if you had said HWW, I would be happy because even I remember it as an HWW. It's very difficult. So, what we have is a duplication of the uterus, cervix, and vagina. And then we have the ipsilateral hematocolpus and an absent kidney on the same side. So, we see that the right kidney is absent. We have this uterus, which is, of course, a double uterus. They have a double cervix and they present with hematocolpus. So typically they present when they start menstruating. So it's a painful menstruation, and typically they present at around 14 weeks of years. But recently we had one case where she was quite asymptomatic for quite some time, and she presented almost at the age of 25 years, which is a little unusual to happen. But most of them, when they start menses, they have painful menses because of the obstruction, and that's when they present. This is also known. This is of course known as Hurley-Wunderlich syndrome, or it's also known as ovira. If someone has written ovira, we should give it to them because that's an obstructed hemivagina and ipsilateral renal anomaly. Very good. Case number 6. What we are doing here is a dynamic scan, and which all of us should be doing for this particular entity.
People are giving the name of the sign, so I think you want the condition also, no?
Yeah, I mean, if they give the name of the sign, it's good enough. That means they know.
Yeah, I think we got the answer.
Okay, who is it?
Asha has written Indian head sign.
Very good. That's good.
Yeah.
So, what is IDEA? IDEA is a short form of the guidelines which ISWAC has published. So that's why I said what an idea. So there was a clue there as well. And as she's rightly said, this Indian head dress sign. So this is a sign specifically meant for bowel involvement in endometriosis. So typically what happens is we see this sort of a zigzag pattern of the involvement of the sigmoid colon, and this is a normal sliding sign where the uterus and the cervix are gliding smoothly over the sigmoid colon. And whenever there is endometriosis, you would see restricted movements. And I think all of us should read the IDEA guidelines, which were published by ISWAC, to be very familiar with deep pelvic endometriosis. Because we diagnose endometriosis of the ovaries, but it is important to diagnose deep pelvic endometriosis as well. Very good. This is easy. Let's see who does the fastest finger. Case number 7. Are the videos playing, Sanjeev?
Yeah, perfect, sir.
Wow. So far, all the prize winners have been pan-India from all over, which is very happy to note.
Yes, sir.
I thought this will come very fast, answer.
Yeah, we've got it from Nitin, sir. We got epididymis torsion first, but I think your answer is torsion of appendix of testes.
Yeah, I mean, okay, we can give, actually, more than epididymis, it is usually an appendigeal torsion. So, but I think we can give.
So it's Nitin who's got it. Torsion of appendix of testes.
Okay, fantastic. Yeah. Fantastic. So, what we need to remember here is that this is a classical appearance, and this is in fact much more common than actual testicular. We see this very often. And they have that blue tinge sign where there's a discoloration on the scrotal wall, which is supposed to be diagnostic. You have this typical appearance. You may not see color flow there. And we need to remember that there are two types of appendages. One is an appendix of the testes, which is also known as hydrated of Morgagni. And the second is an appendix of the epididymis. And both of these are pedunculated. And therefore, both of them can torse. And it might be very difficult to differentiate one from the other. But that's a very common thing which we see in children. Important diagnosis to make. This is, of course, a spot. Only 3-year-old child. And I think Marlene covered this very well that day. This should come very fast.
We've got it already. The
Okay,
answer,
great,
sir.
fantastic.
Yeah.
So
This is Meenakshi Goyal.
okay,
I think she's already won one quiz earlier, so
Oh,
she's
great.
making it a habit here. Yeah.
So that's a ovarian torsion, and what is important is I think Marlene Shahal told us that day that these primordial follicles, which are normally we don't see, they suddenly become blown up, and this is referred to as a mala sign or pearl sign. And what is very important is this right adnexa. There is a whirlpool there, and this whirlpool showed little flow, but the ovary did not show flow. This was only 3-year-old child, and we did a laparoscopy. There were three sort of loops of torsion, and the ovary was blue. So they detorse it, and normally what happens is after detorsion, the ovary color comes back to normal. So in this child, it did not come back to normal for 15-20 minutes, but they left the ovary alone because ovary has dual supply, and nowadays no one does oophorectomy for a torsion. So another companion case. They get it? They got it?
Yeah, so Nilofer has answered ovarian torsion.
Very good. So there are two important things here. One is, of course, that this is an unmarried female, and we on transabdominal, all we saw was some sort of a mass, but we were not able to say what it is, and patient had pain. So in this situation, always do a transrectal ultrasound. So Jyoti just put in a probe, and we can easily see the whirlpool. That's very diagnostic. That's a whirlpool sign, which Dr. Bhupati has written, which we were seeing, but we never wrote about it. And that's a very large ovary with no follicles and no color flow. So the teaching point here is any female with if you don't have, if you're suspecting congenital malformation or you're suspecting anything like this in the pelvis, do not hesitate to do transrectal. It is as good as transvaginal ultrasound. Okay. And of course, we need to have small probes, which most of us have nowadays. Now here again, they detossed. And what happened is for 20 minutes, the ovary did not change its color. That's a tossed ovary. It's very dark blue. But after 20 minutes, it started showing change in the color. That's a video which is running. And again, the thing was conserved. Very good. Fantastic. Case 10. Flu is renal colic.
We are waiting, sir. Nothing so far.
Oh. Should I give a clue?
Let's wait, sir. I think we've got an answer.
Fantastic.
Sloughed papilla we got, followed by papillary necrosis. So I think it's good enough.
That's good enough. Very good. Very good. So the clue would have been a diabetic patient. So here again, two things. One is this patient had colic, and the clue is the sloughed papilla in the kidney, and you're seeing something in the ureter which is not shadowing. Number two, again, what we have done here is a transrectal ultrasound. Okay, so we search calculi. I mean, in our center, we have, if there's a suspected calculus or anything, we have to get it. Whether we do transvaginal, transrectal, whatever we do. So use all your probes and give the clinician an answer. Okay. So the difference here is that there is no shadowing, and it's a very classical sloughed papilla. That's just a 3D reconstruction, because some of our friends like Ravi Kadashle, they're very fond of doing 3D. So we have also got into that habit. And there's a very nice article written by our own friend, Dr. Bhupati, many years back in the Journal of Ultrasound in Medicine, where he described all the features of necrosed papillae giving rise to hydronephrosis. So very good diagnosis by, who was that? Yeah.
This was by Manjusha, sir.
Wow. Okay. Case number 11. This is again very easy.
So हो गया, answer मिल गया, sir.
Good.
Yeah. This is Someone wrote Venetian, but B lines is Sucheta Umbarkar has written.
Very good, Suchita.
Yeah.
So now we have to be very familiar in this COVID era, and we'll see how. So these are discrete vertical laser-like beams. A lines we know are parallel; they come from the pleural reflection, and these proceed down. They don't fade away. Whereas A lines fade away. A lines are parallel. Okay. So and so now we'll have two cases on chest. This is the first case, case number 12. Very classical. And there's a pointer which is actually giving you clues. You want me to play it again?
Can play someone.
Yeah.
Atha has got the answer, sir.
Fantastic. So what we are seeing here is this is very important diagnosis. Whenever you're doing pleural taps, or it's like Asif gave me a case of breast biopsy today, where after a deep-seated mass there was a pneumothorax. So it is very important that we pick it up early on ultrasound. And so what are the diagnostic features here? If you look at this part of the lung, there are no B lines, there are A lines, and we can see absence of the pleural slide. There is no pleural sliding in this area. And number two, of course, is a lung point. So the lung point is basically a point which differentiates the normal lung movements from the point of pneumothorax. A very, very, very important diagnosis, especially in the ICU setup where the patient may be sick, and you can do it from anteriorly. You can keep the patient supine and or maybe even sitting, and you can easily diagnose this. Okay. Case number 13, and a good clue there. This should come very fast.
So we got the answer, sir.
Fantastic.
Dr. Ridwana Ansari. Yeah.
Very good. Fantastic.
Yeah.
So nowadays in this COVID era, we do lung ultrasounds in the ICU, and in fact it has become very popular. So when you see, what you are looking out for are these excessive B lines. So this is known as B7 lines, where you see excessive B lines. So if you have more than 3-4 lines in one intercostal space, and you might have these patches of these B lines at multiple places, and that is very often seen in COVID pneumonias or interstitial. Basically, it tells us there's fluid collection, and we can have patches of this in the lung. So because it might be difficult to do a CT scan in a COVID patient in the ICU, this is very commonly done. So ultrasound, in fact, is playing a very important role in the ICU in COVID patients. Number one is we do lung ultrasound. Number two, we do echocardiography to look for the heart. And number two, we do peripheral Doppler to look out for any venous thrombosis or arterial thrombosis. So portable ultrasound is very, very important under the present circumstances. So any pneumonia, and of course, if you are bilateral and the entire lungs are filled up, then we need to think of cardiac failure or any interstitial syndromes.